Hello and welcome to PharmaZ's pharmacy teaching videos. This video is going to be about antihypertensives and it's a completion of the hypertension guidelines we covered previously. So as a reminder, in that video we covered diagnosis, blood pressure targets and the stepwise treatment ladder. In this video we'll cover the four main antihypertensive drug classes in a bit more detail. So that includes ACE inhibitors, ARBs, calcium channel blockers and thiazide-like diuretics. So looking at antihypertensives in general, these are considered high-risk drugs, and as we've mentioned, doses are titrated up to the maximum tolerated dose over a period of weeks according to the patient's response, side effects and renal function. Monitoring usually takes place before starting treatment, during treatment and when there's an increase in dose, and this includes blood pressure, heart rate, renal function and serum electrolytes, in particular potassium and sodium. Warning signs for antihypertensives include water retention, heaviness in the center of the chest triggered by effort or emotion, depression, extreme tiredness, thirst or excessive urination, irregular heartbeat, muscle weakness and nausea, pain or tightness in the legs which occurs while exercising but disappears at rest, and symptoms of postural hypotension, so that includes dizziness, lightheadedness on standing and blurred vision. If any warning signs were to occur, these should be reported immediately to a doctor. In terms of counselling, to prevent postural hypotension, you may advise a patient to sit up in bed, then stand up slowly first thing in the morning, to drink adequate amounts of fluid daily but not excessive amounts, and to watch out for sodium content in over-the-counter products which can be quite high. In particular, avoid soluble over-the-counter preparations such as soluble analgesics, and similarly watch out for indigestion products like Gaviscon and cough medicines. If they're not sure about the sodium content, then ask a pharmacist. Looking into the different classes in a bit more detail, ACE inhibitors go by the suffix "pril", so ramipril or enalapril for example, and as we've covered, they're one of the first-line treatments for hypertension in patients with diabetes or those under 55 years. They work by blocking angiotensin-converting enzymes from converting angiotensin-I to angiotensin-II, and this therefore reduces blood pressure. ACE inhibitors are best avoided in patients with known or suspected renovascular disease due to the risk of hyperkalemia. If it is to be initiated in these patients, it should be under specialist supervision with regular monitoring of renal function. Although ACE inhibitors are potentially valuable in some forms of chronic kidney disease, they should be avoided in acute kidney injury as they can exacerbate renal failure. And a useful little acronym to remember the contra-indications to ACE inhibitors is PARC. P for pregnancy, A for allergy or angioedema, R for renal failure, and K for hyperkalemia. So if you're sitting your pre-reg exam, this may be a useful little tip for you. In terms of interactions, ACE inhibitors interact with NSAIDs to cause an increased risk of renal damage, with potassium-sparing diuretics and potassium supplements, as both can cause hyperkalemia, and ACE inhibitors taken with diuretics can cause a very rapid fall in blood pressure, especially in volume-depleted patients. Therefore, treatment should be initiated with very low doses. If the dose of diuretic is greater than 80 mg furosemide daily or its equivalent, the ACE inhibitor should be initiated under specialist supervision, and in some patients the diuretic dose may need to be reduced or the diuretic discontinued for at least 24 hours beforehand. If high-dose diuretics can't be stopped, then close observation is recommended after administering the first dose of the ACE inhibitor for at least 2 hours after or until the blood pressure has stabilized. Combination therapy with two drugs affecting the renin-angiotensin system, so ACE inhibitors and ARBs for example, is not recommended due to the increased risk of hyperkalemia, hypotension and renal impairment. So you'll very rarely see ACE inhibitors prescribed with ARBs. In terms of side effects, ACE inhibitors can cause a new onset cough, and this will be a persistent dry cough, and that indicates bradykinin buildup, so patients are often switched to ARBs instead. Common side effects also include hypotension, particularly after the first dose, so you may advise a patient to take their first dose at bedtime to avoid symptoms like dizziness, hyperkalemia, hence the interactions, and rare but important idiosyncratic side effects include angioedema and other anaphylactoid reactions, so patients should seek urgent medical advice if they develop face swelling or stomach pains. Warning signs to bear in mind are related to hepatic effects, so if jaundice or marked elevations of hepatic enzymes occur during treatment, then the ACE inhibitor should be discontinued due to the risk of hepatic necrosis. Moving on to angiotensin-II receptor blockers or ARBs, these are generally used when ACE inhibitors aren't tolerated due to the cough side effect, and they have the suffix sartan, so losartan or candesartan for example. They work by blocking the action of angiotensin-II on the AT1 receptor, so slightly further down in the cascade compared to ACE inhibitors. In terms of interactions and contraindications, they are the same as ACE inhibitors, and in terms of side effects, they're like ACE inhibitors, so they can cause hypotension, particularly after the first dose, hyperkalemia, and renal failure. However, unlike ACE inhibitors, ARBs are less likely to cause a dry cough, as they do not inhibit ACE and therefore don't affect bradykinin metabolism. For the same reason, they're less likely to cause angioedema. We also don't worry about the hepatic side effects as much. If you recall in our previous video, for second-line treatment in patients of Black African or African Caribbean origin, we mentioned it's preferable to add an ARB instead of an ACE inhibitor. And one of the reasons for that is that the incidence of angioedema related to ACE inhibitor treatment is 5 times higher in patients of Black African or African Caribbean origin. So that's why we choose to add an ARB instead. So just bear this in mind as it gives you a bit of a reasoning behind the guidelines. Next is calcium channel blockers, and there are 2 types of these. Dihydropyridine calcium channel blockers are most often prescribed for hypertension, and they have the suffix "pine", so amlodipine or nifedipine for example. Non-dihydropyridine calcium channel blockers, such as verapamil and diltiazem, can be used for hypertension, but are more often prescribed for the treatment of angina and arrhythmias. Calcium channel blockers work by decreasing calcium entry into vascular and cardiac cells, therefore reducing intracellular calcium concentrations. This causes relaxation and vasodilation in arterial smooth muscle, so lowers arterial pressure. Dihydropyridines are relatively selective for the vasculature, whereas non-dihydropyridines are more selective for the heart. Verapamil and diltiazem should be avoided in heart failure, as they can depress cardiac function and exacerbate symptoms, so they can cause clinically significant deterioration in these patients. They can also increase mortality after myocardial infarction in patients with left ventricular dysfunction and pulmonary congestion. Amlodipine and nifedipine should be avoided in patients with unstable angina, as vasodilation causes a reflex increase in contractility and tachycardia. In patients with severe aortic stenosis, they should be avoided as they can provoke collapse. In terms of interactions, beta blockers interact with verapamil and diltiazem to cause an increased risk of cardiac adverse effects, in particular bradycardia. If a patient's taking simvastatin with amlodipine, diltiazem or verapamil, then the dose of simvastatin should not exceed 20 mg daily, as the calcium channel blockers can increase exposure to simvastatin and therefore increase the risk of myopathy. Also, some studies suggest avoiding grapefruit juice with calcium channel blockers, as they can increase plasma concentrations of the calcium channel blocker. Side effects associated with amlodipine and nifedipine are due to vasodilation, such as flushing and headache, which becomes less obtrusive after a few days, palpitations, which is caused by vasodilation and compensatory tachycardia, and ankle swelling, which may respond only partially to diuretics, and these side effects are common. Verapamil commonly causes constipation, and less often but more seriously can cause bradycardia, heart block, and cardiac failure. As diltiazem has mixed vascular and cardiac actions, it can cause a mixture of these adverse effects. There is some evidence that sudden withdrawal of calcium channel blockers may be associated with an exacerbation of myocardial ischemia, so always advise your patient not to stop taking this medication unless they're advised to do so by a doctor. Also bear in mind that different longer acting preparations of nifedipine and diltiazem may not be bioequivalent, so they're not pharmaceutically interchangeable. So prescribers should specify a brand when they're prescribing either of these drugs, and it would be useful for patients to check that they're collecting the brand that they're expecting from the pharmacy. And finally, thiazide and thiazide-like diuretics, which are moderately potent diuretics. They work by inhibiting sodium reabsorption at the beginning of the distal convoluted tubule in the nephron. And in the management of hypertension, a low dose of a thiazide produces a maximal or near maximal blood pressure lowering effect with very little biochemical disturbance. So higher doses are used more often for edema due to chronic heart failure, because there's no point increasing the dose if it's not going to have much advantage on blood pressure control. The guidelines state using a thiazide-like diuretic, so chlortalidone and indapamide are the preferred diuretics to use. Indapamide is claimed to lower blood pressure with less metabolic disturbances, particularly less aggravation of diabetes mellitus, so more often than not, that'll be the one that's used. Bendroflumethiazide is a thiazide diuretic, and it can be used for the treatment of hypertension, but it's no longer considered first line because of a lack of evidence. However, if patients are already stable on this and their blood pressure is well controlled, then they can continue treatment. Thiazide should be avoided in patients with hypokalemia because it can cause cardiac arrhythmias, and hyponatremia. They may also precipitate acute attacks in patients with gout, as they reduce uric acid excretion and cause hyperuricemia. They may also increase plasma glucose levels and therefore exacerbate diabetes. And if a patient has an eGFR less than 30 milliliters per minute, you might as well not bother using it because it's completely ineffective. In terms of interactions, they interact with cardiac glycosides to cause hypokalemia, which increases the risk of toxicity, both cardiac glycoside toxicity, so digoxin toxicity for example, as well as cardiac toxicity. The combination of thiazides with other drugs that lower the serum potassium concentration, such as loop diuretics, is also best avoided, but if it does need to be used, then it requires prompt, intensive electrolyte monitoring. Some studies showed that the effectiveness of thiazides may be reduced by non-steroidal anti-inflammatory drugs, so bear this in mind if you're selling over-the-counter NSAIDs. It's generally best to take the tablet in the morning so that the diuretic effect is maximal during the day rather than at night and it doesn't interfere with sleep. And bear this in mind if you're preparing a blister pack, so the patient's water tablet or their diuretic should be placed in the morning. In terms of side effects, hypokalemia, hyponatremia, and hypercalcemia. And what's quite smart about these antihypertensives is that one of the main adverse effects of thiazides is hypokalemia, whereas one of the main adverse effects of ACE inhibitors and ARBs is hyperkalemia. Also, thiazides tend to activate the renin-angiotensin system, while ACE inhibitors and ARBs block it. So the combination of a thiazide and an ACE inhibitor or ARB is really useful in practice and quite smart because it improves blood pressure control but also maintains that neutral potassium balance. So that's all for antihypertensives. If you haven't already checked out our hypertension video, please do for the up-to-date guidelines which were recently released by NICE. As always, if you have any feedback or comments, please let us know, and keep an eye on our Instagram page where we'll be doing a quiz on this topic. Thank you.